Tuberculosis, or also known as TB, is a historical disease that has claimed the life of many. Centuries had gone by, but promising cure of TB has yet to be found. TB is caused by a bacteria called Mycobacterium tuberculosis. Usually it affects the lungs, but in severe cases, it can also spread to the kidneys, the brain, and the spinal cord. There are two types of TB, latent TB and active TB. A patient with active TB can spread infected aerosol droplets and may transmit the disease to others. Watch out for the common symptoms of TB. There are fever, night sweats, chronic cough, drastic weight loss, and bloody mucus. So what really happens in the body when it's being invaded by the bacteria? As Mycobacterium tuberculosis enters and resides in the lungs, there will be three case scenarios. First is elimination, where the immune system removes the infection. Second is retention, where the immune system suppresses the infection but the bacteria remains viable. This results in latent TB. Third is active infection, where the bacteria evades the immune response. This leads to primary infection of TB. After primary infection, cell-mediated immunity starts to work, and the infection will either be removed or becomes latent. What happens if primary infection occurs? The Mycobacterium enters pulmonary alveoli in the lungs. Then, a member of the immune system called alveolar macrophage eats the bacteria through phagocytosis. The bacteria is then encapsulated, forming phagosome. The phagosome is supposed to fuse with lysosome in the macrophage to form phagolysosome. However, in the case of TB, the fusion is inhibited. The bacteria is protected in the macrophage, becoming hidden away from the immune system. This enables the bacteria to replicate in macrophage, and this process is called macrophage parasitism. How is the Mycobacterium able to inhibit our immune system? There are three mechanisms that enable this to happen. First is the inhibition of phagosome maturation. Under normal condition, UV ATPase pump protons into phagosome to increase the acidity of phagosome. The increased acidity marks the maturation of phagosome. When Mycobacterium tuberculosis is involved, the bacteria releases TTPA protein, which will bind to V ATPase and inhibit V ATPase activity, hence preventing phagosome maturation. Second is the inhibition of interferon production. Under normal condition, C gas will detect foreign double-stranded DNA, activating the STING pathway. This leads to the production of interferon in macrophage. With the presence of the Mycobacterium, as there is no degradation due to the fusion of phagosome and lysosome being inhibited, there is no foreign double-stranded DNA from the Mycobacterium to be detected by C gas. Therefore, there will be no interferon production. Third is the inhibition of phagolysosome formation. Under normal condition, the phagosome has Rep5 protein. Rep5 protein is exchanged with Rep7 protein to mark the phagosome and initiate the fusion of phagosome and lysosome. However, in the case of TB, the Mycobacterium has Rep22A protein. This prevents the exchange of Rep5 protein to Rep7 protein, resulting in no fusion. There is another protein on the phagosome that is involved in the formation of phagolysosome called taccoprotein. Under normal condition, taccoprotein needs to be detached from the phagosome to initiate the movement of the phagosome towards lysosome. With the presence of Mycobacterium tuberculosis, taccoprotein is detained on the phagosome, delaying the formation of phagolysosome. The current solution for TB includes the usage of drugs and vaccine. Drugs can be divided into first-line and second-line drugs. First line is used to combat Mycobacterium tuberculosis. Second line is used to treat multidrug-resistant tuberculosis or MDR-TB. The only available and approved vaccine to be used against TB is the BCG vaccine that is administered to babies. However, the vaccine has its downsides. First, it is only effective at preventing meningeal and military TB. Next, it is less effective against the development of pulmonary TB. Lastly, the efficiency decreases as the person ages. Let's see how BCG vaccine works in the human body. The phagocytes recognize the BCG that is present at the inoculation site. Dendritic cells will migrate to the draining lymph nodes to activate the adaptive immune cells. This particularly activates the mycobacteria-specific CD4 and CD8 T cells with a T helper which secretes high amounts of IFN gamma and enzymes. The activation of B cells will lead to the generation of memory and plasma cells and the production of antigen-specific antibodies in response to the presence of antigens of BCG. There is an ongoing research on TB that involves nanotechnology. The nanotechnology for diagnosis and treatment of TB has been the topic of interest as it can sustain and control the release of drugs, which will increase bioavailability. However, nanotechnology is not yet established due to various reasons. This includes lack of human trials, requires trained medical professionals, and it is also unfeasible in low-income conditions due to its high maintenance and storage. To conclude, new technologies for TB are needed which are to rapidly identify individuals with active infectious TB in the field, to improve TB treatment, to curb TB transmission, and to reduce morbidity and mortality.